Good afternoon, everybody. This is Murphy Alexis Mowry of National American University. I am shooting the video for assignment 8.1, the course of Strategy and Policy, Masters of Management. Today's date is December 1st of 2020. Today, what we are going to look at are the issues facing healthcare. We have chosen 3 categories of disease prevention, patient care, and delivery of care. Alongside of those topics, we're going to look at the current COVID-19 responses in the United States, Sweden, and New Zealand. The next slides are going to go through the best practices of each of these categories, along with the response of medical staff, the response of healthcare providers, and the impact on future health projects and the health sector. Right now, we're going to look back to the current history, and in November of 2019, the rumblings of a ravaging disease began to hit the international newswire. All inquiring minds knew, and what was reported was the disease belonged to a flu virus class, and no treatment was available for distribution. In 3 weeks, China gradually closed down the Wuhan city in the Hubei province, hoping to isolate and avoid the spread of the disease. And this meant trying to trap the movements of millions of people traveling overseas and those with families who were traveling to visit their families during the upcoming Chinese New Year. By the 6 weeks, the virus gained a name, the coronavirus, and a designation of COVID-19. Inside the United States, the health response was swift and immediate. The first case was reported by the University of Washington Medical Center on January 30th of 2020. The state with the most successful care in treating COVID and preventing cases has been Minnesota. The insurance company that has participated the most in giving care and providing for care is the state program of Medicaid. Hospital care inside the University of Washington, they found out that for their most critical cases, they used telehealth visits even inside the hospital. They kept rules about social distancing. They regulated their equipment. They only used ventilators when needed. They used PPE properly. And as the program expanded in treatment, they started to do prior home screenings with at-home kits. And the first drive-through testing area was done in the parking lot of the University of Washington. The best steps towards recovery as people were treated by the university was a positive outlook, correct supportive care, therapy, which included exercise, ventilators, vitamins, and self-quarantine. Along with this, disease prevention steps that were offered by the United States included social distancing, limiting outside trips, educational brochures, national brochures, and practicing excellent hygiene. This also included education about masks, what benefits a mask provided, and how to use a mask. Overall, the delivery of care in the United States was delayed due to rumors, bad information, a slower crisis response, the concerns about vaccine development. The medical system in the United States contributed to these delays and issues because the system is both private and public. The determining factors on insurance and how people receive care have such variables as income and financial solvency. By financial solvency, I mean the type of insurance that an individual carries and the type of group care that is offered, let's say, by an employer or another entity. If somebody had insurance and a great deal of income, that helped them get better, more immediate care, leaving those with less finances and less income to suffer other fate. And truthfully, insurance and the amount that an individual holds monthly, it did play a role with how a patient was treated and how quickly a patient recovered. Patient participation inside the United States is resistant. It is based on belief, the region, what the resources are available in the region, whether somebody has strong individual self-determination, and the education level of the patient. In the health response of Sweden, the first cases were reported later in the year, as late as February 29th. The most successful treatment of COVID cases has been at the University of Stockholm Medical Center. Sweden is different than the United States because Sweden has a single central health system. Those health systems then correspond to regional clinics. If a missive is given out by the Department of Health, those messages and information are then distributed by the central hospital to regional clinics. Hospital care in Sweden suffers from a different set of issues, which are commonly determined by age, the condition of the patient at entry upon hospital admission, and the recovery possibilities of the patient. Meaning, if somebody is older and has a slighter chance of recovery, they will not get the full range of treatment. For the cases reported in Sweden, the best steps towards recovery have been immune response therapy, the regulation of breathing through ventilator use. There has been successful trials of antiviral medication, isolating the patient so that way there is less cross-contamination, and exercise. In Sweden, disease prevention of COVID-19 relied on central requests. The hospital system issues a missive. That hospital then corresponds with regional clinics, and the regional clinics are then tasked to take care. Community isolation also plays a factor in how people are treated in Sweden. Some villages and major towns are actually in very rural, dissociative and dislocated areas of the country, including some that are above the Arctic Circle. That meant that there is limited travel to those areas, which makes receiving and getting medical supplies an issue. But overall, if the government issues a decree, the Swedish people will follow because they trust their government and they trust that their government has their best interests of heart. The delivery of care in Sweden has been quick. It's been reliable due to the fact that there is one governing organization and there is one streamlined system of medical care. There's also great access to university research and therapy development, which happened very quickly in Sweden because there's not as many regulations or red tape, bureaucracy, and extra offices to go through. So for Sweden, the people readily agreed to follow what the authorities and the government asked them to do, which was to remain alert, to practice good hygiene, use social distancing, isolation, and if they really felt like there was a medical problem, to call their local municipal leaders and their local doctor to help with symptom treatment. In Sweden, community news is shared. There are 3 major television stations. Therefore, if it is an important topic to the Swedish people, those 3 stations will collectively agree upon how the information will be shared. Because there is one central system, municipal support is easy to come by in Sweden. If a mayor or an official decrees that the people should follow one system, it is then followed and trusted as such. In New Zealand, the first case was reported by a dual citizen of New Zealand and China who had traveled to China to see family. The most successful care centers have been in the capital city of Wellington and with the Iwa tribal community on the North Island at the very tip of the country. The most participants of insurance in the New Zealand community has been through the Central Government Department of Health and what's known as the ARC. The ARC stands for Aotearoa Regional Committee, which is a group of community leaders dedicated to helping the native tribes and the Maori tribes of New Zealand. Hospital care leaders then relied upon predictive studies that have been seen and participated in through previous and other epidemics. The Canberra Conference of 2008 was addressing the presence of bird flu, and the Pan-Pacific Medical Conference of 2011 addressed the issues of swine flu and H1B1 flu. So the best steps of recovery in New Zealand have been the central response of the government, where it has shown a unified message across all levels: federal, municipal, district, and towns. New Zealand also had taken into account a 4-tier level response of emergencies, especially after bird flu and swine flu. This then responded to the empathy of the PM, who delivered daily messages to the population of New Zealand to help people gain a better understanding of what was happening. In disease prevention, New Zealand has been exceptional because they have shown the effort of a central message, and that message has been delivered to community leaders and then stressed to the community. There has been a collective emotional decision of the people in New Zealand. These are then supported by daily briefings, which are coming from the Prime Minister's office. The hospitals are regional medical centers. They have connections to rural providers and the Department of Health. In New Zealand, the delivery of care has been carefully managed with full support from the government. If somebody comes in and they are ill, they are sick, they're immediately taken to the emergency room and given care. There is no priority system, no ageism, ethnic bias, or discrimination. Patient protection and participation has been fully supported by all New Zealanders and Maori. These support lessons are learned from past experiences. They have a good supply chain and equipment available, along with agreements with other countries and the university system. Shared practices of all 3 countries. The common points of response. All 3 have acknowledged the presence and promoted better hygiene, social support, and efforts to educate the public. Prevention techniques. All patients have used technology, expanded tutorials on how to use technology and benefit from telehealth, along with creating isolation areas in treatment, trained staff on triage and medical emergency work. Patient participation has depended upon education level, the level of trust of the people in their government. Does the government have a consistent message? And regional awareness, i.e., where is COVID cropping up and how fast the disease is being treated and flattened. The delivery of care common to patients of all levels. In all 3 countries, there have been trained medical staff, development of triage procedures, symptom screening, and coordinating efforts of medical and municipal leaders. So, overall rankings based on the data provided. For disease prevention, the United States ranks 3rd. It ranks 2nd in the delivery of care and 2nd in full patient and population participation. Sweden is 2nd in disease prevention, 3rd in the delivery of care, and 1st in full participation of the population. New Zealand has had issues, but they rank the swiftest in disease prevention. They are top tier in delivery of care and 3rd in patient participation. This is a graph showing the following data. Unfortunately, the graph ended up getting deleted, so this is what we have. The United States is the country in blue, Sweden is the country in green, and New Zealand is the country in red. The response of medical staff overall. The common points are that health visits through applications, i.e. phone and internet calls, are helping educate and reach more people at home since travel has been limited. Test kits are being delivered, mailed, and distributed to all rural clinics. In Sweden, people are still able to move about with some freedom, and the Swedish government has actually been the source of some international, I would call it finger pointing and international jokes, because they don't seem to take COVID seriously. They do, they just have a different way of showing it. In New Zealand, the curve has flattened because the Prime Minister and the Department of Health sent out extensive assistance through education and municipal involvement with a community care-based focus. And the difference in regional needs, income, and planning have the United States still scrambling. We do not have a single crisis plan that is uniform throughout the states. So, the response of healthcare providers is that those who are needing care in all three countries are receiving care. Plans are being made by each individual government to distribute the new vaccines. The model from the University of Washington Crisis Response Team is helping promote better crisis response plans, and it shows that medicine is now embracing technology. In contrasting points, we have the United States and Sweden. Crisis cases are given ranked priorities. Those who show the most detriment and the highest rate of infection are often given low priority of care because the case may not make it and the person may not recover. So cases with the best chance of recovery, they receive the most care in hospitals, which ends up discriminating and ranking. In New Zealand, a proposed community-based care initiative which unified the country, and it helped the whole population participate in modifying social and cultural behavior. So, how has this changed in the medical sector? Well, the medical sector now realizes that there needs to be an overall crisis response. This includes insurance providers who are now asking people about their policies and about COVID exposure. Certain insurances will not insure an individual if they have already been affected or already had contact with COVID. Medical staff, they want to know when a vaccine will be ready. This is especially important because oftentimes hospitals and emergency rooms are the first location of care. And hospital care are trying to fill staff positions and hire qualified, competent assistants to help with phone, triage, and medical screenings. The sectors that are affected in society is that at-risk groups are being asked to report on health status. Therefore, medical privacy is now becoming a tricky thing of the past. Also, social behavior is showing signs of isolation, mental illness, fatigue, and stress. People are not doing well. People are having trouble because they can't correspond and move with freedom. Institutions are now being affected because there's a race towards developing a care plan and a vaccine before winter. In New Zealand, one of the things that influenced care was the fact that when COVID hit, it was in the springtime and not in the wintertime or full summer when most microbes can be passed easily. In conclusion, the current pandemic has shown the world all citizens can be affected by disease and travel. There is no one country who has not felt major social changes. The best ways to cope are to remain aware, restrict travel, and continue the investigation to find the source of infection and share the best care practices. A return to daily function will ask every man and woman and child to adapt and change physical actions along with the social behavior. Danger has a new virus to compete with, and crisis teams are improving with new therapeutic approaches and vaccines ready to deliver. These following slides have the references that have been used in preparation of this presentation. Thank you for joining me. I hope you enjoyed this presentation. Have a wonderful day and a wonderful holiday season. Thank you.